So let's talk your role in your documentation as it applies to reimbursement. And I know you're thinking this is boring. I don't care. But do you want your QI officer off your back? I bet you do. Do you want medical supplies on your truck? I bet you do. Do you want to get paid? I bet you do. Because our budgets, so most budgets for ambulance services, and in this context, we're talking about 911 EMS agencies, our budgets are tax supported sometimes, and sometimes not tax supported or not completely tax supported. So, a lot of revenue, a lot of operating funds for your agency are going to come directly from billing. So, with that, we need to know how much things cost and how much revenue we are bringing in. So, what do things cost? Well, how much do these things cost? Think about an ambulance. Ambulance can cost anywhere from 100,000 to 150,000. That's just for the vehicle itself. That's not outfitting it. That's not stocking it. That's just the vehicle. The wheels, the steering wheel, the box, the engine. That's it. A Life Pack 15, you've been playing with those. So Life Pack 15 can go anywhere from $30,000 to $40,000, depending on options. So just one monitor on one truck, $30,000 to $40,000. IV catheters, you think, I'm going to try for 3 or 4 IV attempts on my patient. Well, each IV catheter is usually around $3-ish per catheter. So every time you attempt an IV, that's like $3 right there that you've just spent. What about that stretcher? You're taking it in and out of the ambulance every day. You're throwing patients onto it, sticking it back on. A simple stretcher, about $5,000. A power stretcher, we're talking double that, around $10,000. And then there's you. There's the employee. You cost a lot. There's your salary, and then on top of that are your benefits. So, to start, let's talk about just healthcare billing broadly. So, we've got fee for service. And if we're thinking about our EMS agency, this is where the healthcare agency or EMS agency bills for the services that were rendered. So, we can bill for response, we can bill for mileage, we can bill for disposable supplies. On the other end is capitation. That's where a healthcare provider is paid a flat amount for every patient that provider serves, regardless of the services that are rendered. So for EMS agencies, we bill under a fee for service model, not a capitation model, because, well, we don't know who our patients are going to be day to day. But a primary care provider might function under a capitation model where they're paid a flat amount for every patient that they serve, no matter what they do for that patient. And what this looks like is kind of this McDonald's versus like a Golden Corral buffet. So our fee for service is our McDonald's. You walk in, you want a hamburger, you buy a hamburger. You want French fries, you buy French fries. You want a drink, you buy a drink. If you don't want French fries, then you don't buy French fries. So you only pay for what you want, what you get. Um, the McDonald's restaurant is only charging you for what you get. On the other end of things, you've got this buffet. You pay a flat fee and you walk in and you get whatever you want. So you can have one very small plate of food, or you could have 3 or 4 or 5 really, really large plates of food, but you still pay the same, let's say $15 to get in. So that's kind of our capitation. So under this capitated model, if I go in and I have this really small plate of food, well, that restaurant, that healthcare provider, is going to profit off of that. If I get 4 or 5 really, really large plates of food for the same amount of money, well, that restaurant's going to lose some profit there, and that healthcare provider might lose some profit. So there's a give and take under capitation. For fee for service. You're paying, we're billing for exactly what we are providing. And under this fee for service, we bill under these ICD-10 codes. You might hear ICD-9, we're up to the 10th version, so they're ICD-10 codes. These ICD-10 codes get very, very specific. So these are the International Classification System. So very specific codes for disease processes. So you can see right here, the W5541XA, bitten by a pig. It's very specific ICD-10 code. We've got sucked into a jet engine. There's a very specific ICD-10 code. All of these codes have payment amounts tied to them. For Medicare purposes, they use ICD-10 codes, but we're going to start with DRGs, these diagnosis related groups. So DRGs used by Medicare. These DRGs are much less specific than ICD-10. There's no bitten by a pig. So we've got DRG 291, just heart failure. So on the Medicare side, we're going to be billing and being reimbursed based on DRGs. All right, so we've got fee for service, we've got capitation, we've got ICD-10 codes, we've got DRGs. Let's talk about ambulance and EMS reimbursement in particular. So reimbursement for us, payment to us. Medicare takes up about half of that, a little less than half of that, about 45%. Another 20% is made up of private insurance. We've got Medicaid at around 15%, self-pay another 15%, and then kind of other that might be like workers' comp, um, uh, taking up the rear. Now we've got all these payers, so we send out a bill, we bill them, but will they pay that bill? That's kind of up to them. So our insurers kind of decide how much to pay us, especially Medicare. Medicare really strictly defines exactly how much they're going to pay us for each patient. So we can bill whatever we want. That doesn't mean these insurance providers are going to pay us. So each year we see about $3 billion in uncompensated EMS bills. And that gets into the definition of a collection rate. So our EMS agency, we choose what to bill, but then that payer chooses what to pay. So we can bill Blue Cross Blue Shield. That doesn't mean they're going to pay the entire bill. So the collection rate is the percentage of that bill that we got. It's just a proportion. So we send out a $1,000 bill to Blue Cross Blue Shield or Medicare, we get $300 back. That's a 30% collection rate. And believe it or not, but 60% is pretty good. You'll see agencies above that, agencies below that, but 60% is a pretty good average for a collection rate. And if we want to increase our collection rate, or keep it high, there are things that we can do, that we need to do to ensure a higher collection rate and increase reimbursement for our EMS agency. Because remember, that's paying for you, that's paying for your supplies, that's paying for your equipment. So, what is our essential documentation that we should be paying attention to? So we've got a couple definitions here for you. We've got necessity and we've got reasonableness. And we need to document both necessity and reasonableness because billing agencies and insurance companies are going to be looking at this. So necessity, so it is the transport is necessary if any other transport method is detrimental to that patient. And that transport must be to obtain a medical service. So, keeping it in the back of your head, knowing that a transport to the ER just to fill a prescription is not a medically necessary transport. So, that does not meet necessity. So, necessity, the patient must go to the hospital for medical treatment and must go by ambulance, otherwise, it would be detrimental to their health and well-being. Reasonableness is that the level of service that you provide during that transport matches the patient's medical need. So we can't bill, let's say ALS2, and we'll get to that here in a minute or two, but we can't bill for a higher level than is rendered. So even though we're completely capable of doing all these amazing things on the ambulance, if all the patient needs is a cold compress on their knee, then that's all we are billing for, and that's what we're providing. Another definition we need to be cognizant of is bed confinement. So, bed confined is defined as a patient who is unable to get up from bed without assistance and unable to walk around, unable to ambulate without assistance, and unable to sit in a chair or wheelchair. So a patient must be I should say, if we are defining bed confinement and saying a patient is bed confined, they must meet all three of these criteria. And this is going to be important in our interfacility transports and our medical transports when we get to those here in a few minutes. And that brings us to our necessity form. So, on interfacility transports, on medical transports, we're going to need some sort of necessity form. So, we need a certification of necessity. So, thinking back to our definition of necessity, we need a necessity form. This is something that's signed by a physician and declares that a patient cannot be transported by any other means other than your ambulance. We don't need this for 911 responses. Necessity is assumed in 911 responses, so we're just kind of focusing on interfacility medical transports here. There is a 30-day option with necessity forms. So you've got your patient who goes to dialysis 3 times a week. You don't need a necessity form every single day of that week that you transport them back and forth. As long as you have this form and the 30-day option is checked and signed off on, as long as you have that form on file somewhere in your agency's office, that is just fine. So this necessity form, check it. Make sure it is truthful. Too many times physicians will just sign off on this necessity form just to get a patient out of the ER, out of the hospital, to get them discharged. If they do that and it is not truthful, does not meet true necessity, then it is insurance fraud, and you are now culpable. You are now part of that fraud if you take part in that. So check the form, make sure it's truthful. If it is not, then take it to up the chain to your supervisor, to a nursing supervisor, the hospital, to the physician themselves. Just make sure it is not fraudulent. And I say make sure it's not fraudulent because there are some big penalties here. So here's an ambulance company. $1.25 million of unnecessary services, not medically necessary. And you know what? Medicare, CMS caught wind, and the owners, right, up to 10 years in prison for each count of healthcare fraud, along with fines. So this isn't something to shrug off. Insurance companies and Medicare really pay attention to these things. So your essential documentation is going to differ a little bit between 911 and interfacility or medical transport. In the 911 setting, necessity and reasonableness are assumed. So no big deal there. But we do need to be transporting to the appropriate facility. We're going to need to be documenting our patient assessment and who did the assessment. Was it a paramedic? Was it an advanced EMT? Was it an EMT? And then the services provided. So we'll need to be documenting any supplies used, any medications that we administered, and any procedures that we performed, because all of those are billable. And on top of all that, we can bill for mileage. We'll get into mileage a little bit more here in a few minutes. We can bill for mileage, and we need to document signatures. So lots of signatures, your signature, your patient's signature, for HIPAA purposes, for insurance and billing purposes, the receiving facility's signature saying you transferred care. And then, if you're talking about refusals, we're talking so the refusal signature itself and witness signatures, and probably your partner's signature. So we need to be documenting all of these things. Now, in the non-emergent setting, this is interfacility transports or medical transports. We've got necessity and we've got reasonableness. These are not assumed like they are in the 911 setting. So under necessity, we're going to have that necessity form. Under reasonableness, we're going to have within that necessity form is some sort of documentation of reasonableness, and the patient is bed confined. And remember that bed confinement has those three criteria that the patient must meet, all three of those. If they don't, they can be transported via other means. If they can sit upright in a wheelchair, they can go by a wheelchair van. They don't need a stretcher in an ambulance. So we need a necessity form. Within that necessity form is usually that reasonableness, so check it. And then we need to be going to the appropriate facility. That's going to include a what we call a COBRA form. So that COBRA form tells us and kind of certifies that the patient is going to the appropriate facility, and this is for interfacility transport. So we're going from Harris to Mission, let's say. And it says that the patient is going from Harris to Mission to receive a higher level of care. We just can't punt a patient over to another hospital just because we want to, just because we don't want to deal with them. So this patient is going from Harris to Mission for a specific purpose. They're going there for the cath lab. They're going there for ortho. They're going there for a neuro assessment and neuro treatment following a stroke. So there is a necessity to go to this newly appropriate facility. And this whole new form here, this COBRA form, comes out of EMTALA, the mid 1980s. It's the Emergency Medical Treatment and Active Labor Act, and this is part of it. So the COBRA form, you need a transferring physician signature. So you have a physician saying this patient must go to this other hospital for a higher level of care. You must have the name of the receiving physician at that other hospital, because you don't want to show up at the other hospital and not have a place for this patient. So you need a transferring physician, you need a receiving physician, and you need the name, at least the name of the nurses and the time of report. So you need the name of the transferring nurse and you need the name of the receiving nurse at the other hospital. And there's going to need to be a time of report that the transferring nurse gave report to the receiving nurse. And this all comes because of patient dumping. So in the 70s into the 80s, saw a problem of hospitals just kind of punting patients because patients didn't have insurance, couldn't pay, and a hospital would punt them to a private hospital would punt them over to a county hospital, and en route, the patient's condition would worsen, and patient might die. So there's this patient dumping issue. So we want to be making sure that when a patient is going from hospital A to hospital B, that they're going to hospital B for a reason, and that reason is a higher level of care. And that gets us into the destination itself. So, what is the appropriate facility? So, in the 911 setting, you pick up a patient, we want to be going to the closest appropriate facility. And that appropriate definition changes a little bit depending on your patient's needs. So, if they have a sprained toe, absolutely, in Cullowhee, absolutely go to Harris. That is the closest appropriate facility. If they're having a STEMI in Cullowhee, the closest appropriate facility now becomes Mission in Asheville. So the closest appropriate facility might change a little bit, but CMS, Center for Medicare and Medicaid Services, and just about every private insurer will pay mileage, reimburse us mileage to the closest appropriate facility. Anything additional to that is a responsibility of the patient. So if they've got that sprained toe, you want to take them to Harris, they say, no, take me to Mission. Well, we can get reimbursed for mileage up until Harris, and then any mileage between Harris and Mission is the responsibility of the patient and will be billed to the patient. Okay, we've talked a little bit reimbursement and documentation and forms and how all of that, right? So let's kind of dig into some billing levels. And we're going to focus on Medicare because Medicare kind of sets policy, and then most private insurers follow Medicare policy. So there's the Medicare Transportation Benefit. It is under Medicare Part B and states explicitly, and this is straight out of Medicare policy, that the Medicare ambulance benefit is a transportation benefit. And without a transport, there is no payable service. I want you to read that again. Without a transport, there is no payable service. So, under Medicare, if we do not transport the patient, we do not receive any reimbursement. And most insurance companies follow this policy. Okay, so going forward through these billing levels, we're going to be assuming that we are transporting this patient. So, whatever patient we are transporting, now we get these service levels. So, we've got two BLS service levels that we can bill at. And these are Medicare billing levels. And again, most private insurance companies follow Medicare policy. So we've got BLS and we've got BLS emergency. So BLS, we've got basic life support services are rendered even if a paramedic is part of a crew. So you've got that patient with that sprained toe. If all you do is put him on a stretcher and sing him a lullaby, right? Even if there's a paramedic on the truck, we're billing at a BLS level. BLS emergency is just a non-scheduled transport. So BLS emergency is a 911 call. BLS, just BLS is a medical transport, a scheduled medical transport. Moving up a notch, we go to ALS, and this is ALS 1. So we have ALS 1 and ALS 1 emergency. So we go from BLS to ALS 1 when there is an advanced life support assessment and at least one ALS intervention provided, like an IV, or in most cases an IM injection, or maybe a medication administration. So ALS 1, ALS 1 emergency. Again, the emergency just denotes a non-scheduled transport, so a 911 transport in most cases. ALS 1 just on its own is a medical transport, interfacility transport that has been scheduled. Then we can ramp it up to ALS 2 if at least 3 separate IV medication administrations have been given. They can be the same medication. You can give Zofran 3 separate times, and that becomes ALS2. It doesn't have to be different medications. It can be the same medication, but it has to be given IV or IVIO. So 3 separate IV medication administrations, or one of these kind of big interventions. You defibrillate, you cardiovert, you pace, you intubate, or create your own airway. You've got a central line or an arterial line, or you needle decompress, you do a chest decompression. Even just starting an IO bumps it up to ALS2. So either giving 3 separate medications, IV, or one of these um, big interventions automatically bumps it up to ALS2. And then we've got a couple other service levels, billing service levels outside of the BLS and ALS. We've got specialty care transport, that's SCT level, and these include services beyond the scope of a normal paramedic, of your kind of everyday paramedic. So think of this, this is your critical care transport. The caveat here is that the state, some states actually recognize a critical care certification or licensure. North Carolina does not. There is no Office of EMS critical care paramedic certification. you can go and take the critical care course, whatever critical care course you want. You can take it, you can take whatever exam you want, you can get whatever patch you want, but in North Carolina, the Office of EMS does not recognize critical care paramedic as its own certification. So, in North Carolina, if we want to bill at the SCT level, we have to have someone else on board as part of the crew. Usually that's an RN. Sometimes it might be a physician or a PA or nurse practitioner. But that's why as you go across the state, you usually see critical care crews in a configuration with a nurse and a paramedic. So we can still bill at the SCT level. If we have just paramedics on board, all we can do is bill at the ALS 1 or ALS 2 level, depending on what we're doing. We can't bill at the SCT level. But in states that do recognize a critical care paramedic certification as part of their state certification, like let's say Wisconsin. Wisconsin does that. You can have a paramedic or two paramedics on board and bill at a SCT level. The last one we'll talk about is the paramedic intercept. This is kind of a trickier one. So to bill at a paramedic intercept level, the agency must be non-transport capable. That agency must intercept a BLS ambulance that does not bill for services, and the intercept agency will provide the ALS service during transport. So, as an example, long ago and far away, I did my freshman year in Albany, New York, and worked for the volunteer ambulance service on campus there in Albany, and we covered a 5 mile radius there in Albany. Albany, for the city, Albany Fire provided a paramedic QRV. For all medical calls, the paramedic was dispatched, as was the volunteer agency that I was working for. So our volunteer agency and that QRV met at the scene. So Albany Fire with their paramedic was non-transport capable, just in that QRV. We were a BLS ambulance as the volunteer agency. We did not bill our patients as a volunteer agency, and if the patient needed ALS, then the Albany Fire paramedic jumped on board our ambulance and rode in with the patient. So Albany Fire would be able to bill at the paramedic intercept level. And now with all those billing levels, I'm sure you're thinking like, who cares? I don't care. No one cares. But let's kind of put this all together. So we've got all these different reimbursement, like billing levels for our patients, and we're talking CMS, so Center for Medicare Medicaid Services, and reimbursement. There is a base rate reimbursement. So all of these different levels that we just talked about, BLS, ALS1, ALS2, SCT, paramedic intercept, these are all dependent on this base rate. So for a patient you pick up who is covered by Medicare, and remember that most private insurers follow Medicare policy, you pick up this patient covered under Medicare, there's a base rate. Right now, that base rate for transport is $229.91. That's what we get. But if we bill at a different level, depending on that reimbursement level that we just talked about, we're going to apply a relative value unit to it. So it's an adjustment of that base rate dependent on the service that we provided. And then on top of that base rate, we can add mileage. And the reimbursement for mileage changes a little bit or differs a little bit from urban to rural areas, but we can add mileage onto that. And then there's also this kind of regional cost adjustment as well that's added onto it. So there's a base rate. We adjust it based on our billing level that we just talked about. We can add on mileage, and then at the very end, there's a regional adjustment. And here are your relative value units, your RVUs. So BLS, that's where we start. BLS, a review of one, that's our base rate, $229.91 for a patient transport, no matter what you do for them. $229.91. And then once we get into BLS emergency, we ramp up a little bit, so we go up in price. So 1.6 multiplied by $229.91 gets us to $367.86. And we just kind of start ramping them up. ALS 1, ALS 1 emergency, ALS 2, SCT is the highest at 3.25. So 3.25 multiplied by this base rate gets us to like $745. So that's really important why your critical care agencies in North Carolina will make sure to put uh, a paramedic and a nurse or someone else, or respiratory therapist, someone else on that truck, so we can bill at the SCT rate instead of like an ALS2 or an ALS1 um, RVU, right? So it ramps up to 3.25 all of a sudden. Your paramedic intercept is a little bit lower because lower overhead, lower costs overall for that QRV, but there are your relative value units. So we've got our base rate, and then as we apply our different billing levels, we've got a different multiplier on that base rate. If you're thinking, what about multiple patients? I can transport 2 or 3 or 5 patients in my ambulance. For private insurance, private payers, it kind of depends on the policy and the payer. For Medicare, let's say you're transporting 2 patients in the same ambulance, you get 75% of the base rate for each patient. And you get 50% of the mileage for each patient. So you get a little bit of a bump for the billing level for that base rate, and then you split the mileage for each patient. And speaking of mileage, we've got a few different definitions of mileage. We've got loaded miles, which is our scene to our hospital. So our patient is in our ambulance. We're going from our scene to our hospital. CMS, the Center for Medicare and Medicaid Services, actually allows for us to bill and be reimbursed for hospital to base mileage as well. So, um, you know, be cognizant of that. So if you're going back to your base from Mission, let's say you're going from Mission back to Silva or back to Cullowhee, CMS actually allows us to bill for that mileage. But what is the CMS rate per mile? It's about $7 per mile. It's going to differ a little bit for rural areas. It's going to be a little bit higher for miles 1 through 17. I don't know why they picked the number 17, but there it is. But almost $11 per mile for those for 17 miles, and then it kind of bumps down a little bit. But about $7 per mile is what we're going to be reimbursed for. Okay, so let's put all of this together and go through some examples. So, our first one, we've got a 73-year-old male, STEMI, put him on oxygen, give him some aspirin, start 2 IVs, give him some nitroglycerin, do a 12 lead, which confirms a STEMI, tells us it's a STEMI. I give him 1 dose of morphine, transport him to the cath lab, and we're going to bill $1,200 for all of that. So, what billing level do you think? We'll give you a second here to think about it. What billing level do you think that we're going to be reimbursed for? So, for this patient, this is going to be an ALS 1 emergency. So we're assuming it's a 911 call. So ALS 1 emergency. So it's ALS 1 emergency because we haven't done one of those big ALS 2 procedures. We didn't start an IO, we didn't defibrillate, we didn't needle decompress, and we didn't give at least 3 IV medications. We gave 1 IV medication. We gave morphine. We started 2 IVs, but we gave 1 IV medication. Nitro sublingual, aspirin's PO, oxygen, might have been nasal cannula, might have been non-rebreather, but it wasn't IV. So we're at ALS 1 emergency. So we billed 1,200. We collect 500, so we have a collection rate of 42%. Our second patient, a 67-year-old female, humeral fracture. We splint that humerus, start an IV. During transport, we give her fentanyl twice for pain. We give her Zofran for a little nausea, and we transport to the closest hospital. We bill $1,000. So, what billing level do you think this will fall under? This is going to be an ALS 2. And even though, from patient 1 to patient 2, seems like we did less for patient 2. But we gave fentanyl twice as an IV medication. We gave Zofran, and here I'm kind of assuming that we're giving Zofran IV and not like sublingual or like a dissolving tablet. So fentanyl times 2 IV, Zofran IV. That's three separate IV medication administrations. We can bill at the ALS2 level. So we billed $1,000, we get $650 from that, and our collection rate jumps to 65%. Our third patient here is an 88-year-old female, cardiac arrest. We do CPR, we defibrillate 5 times. We start an IO, we intubate, we give epi 7 times. We've been working him for a while. We give amiodarone twice, and after an hour of working this patient, we call him on scene. We stop resuscitation efforts on scene. The bill itself is $1,400. So what what couple questions. What level do you think we will be billing this as, and what do you think our reimbursement rate will be? Well, we can bill at an ALS2 level because we did a whole bunch of stuff. All these like big ALS2 things, right? We defibrillated, we started an IO, we intubated, and we definitely gave 3 or more IV medications. But we collect zero, and we collect zero because we didn't transport. We we stop resuscitation on scene. So CMS, Medicare says we will not reimburse you unless you have transported. Our last patient is a 60-year-old male who fell and has a skin tear. You're on scene, you're a paramedic, you do your paramedic assessment, you do your C-spine clearance, you clean the wound, dress the wound, and then just transport to the closest hospital because he wants to go to the hospital for further evaluation. We're going to bill $1,100 for this, and I'm just kind of making these numbers up, but let's say we're billing $1,100 for this. What level do you think we will be reimbursed at? So this is going to be a BLS emergency. So we're assuming this is 911. This is non-scheduled, so BLS emergency. We're going to collect $350 from that. So a collection rate of 31%. It's BLS emergency because we didn't do anything ALS. Even though you are a paramedic and you did a paramedic assessment, that doesn't matter. We didn't do any ALS interventions. Didn't provide any ALS services, so it stays BLS. All right, let's wrap this up and just say, like, so what? Who cares? I don't care. You don't care. My partner doesn't care. So what? Well, if you don't document properly, your agency isn't going to collect enough revenue, and then your agency will have to downsize or close, and you won't have a job. That's so what? If you do it wrong, it's fraud. It is insurance fraud. Your agency will be fined. They'll have to pay these fines. They'll have to pay back any collections, any fraudulent collections. Your agency will downsize or close, and you won't have a job. That's the so what. And of course, the rider to all of this is we're always going to treat the patient. So do not overtreat. don't don't over medicate your patient. to try to get from an ALS1 to an ALS2 level. Please don't do that. Don't provide ALS procedures for a BLS patient if it's not necessary. Please don't do that. Don't go against your cardiac arrest transport protocols. If your cardiac arrest protocols say work it on scene, and if it's non viable to call it on scene, do that, right? We're not going to be doing things to try to get us like 50 extra dollars. Please do not do that. Because not only is it, unethical, and just not right, but every insurance company out there has a team of physicians reading your PCRs. If you think that your PCR just gets filed away somewhere and like no one ever sees it ever, you are completely wrong. Lots of people are reading your PCRs, are reading your reports, and every single insurance company has a team of physicians reading through these, looking for discrepancies. And they will catch these discrepancies. So please treat your patient, treat them appropriately, and don't overtreat, don't undertreat, don't go against your protocols just to try to kind of ratchet up the billing level for that call. If you have any questions, comments, concerns, cuss words, please always let us know.